My name is James Rembert. I'm a radiation oncologist. I work at Diablo Valley Oncology, and as she said, I'm the medical director of radiation oncology at Altabates Summit. Brain tumors are kind of near and dear to my heart. I was actually hired to come to Altabates from UCSF to start a stereotactic radiosurgery program there about 13 years ago. I'm proud to say that's been up and running now for about 12 years, and we've treated hundreds of patients in the community with radiosurgery, whereas previously they would have been going to academic centers. So tonight we're going to focus on kind of a broader overview of radiation. Many of you, if you have brain tumors or know someone who has had them, very often get types of radiation and really don't understand what it is or why it works. And I'm hoping today that at the end of the talk that you'll know a little bit more about that. This first slide is going to be kind of our roadmap to the talk. I think when patients first encounter really anyone in medicine or have to dive into kind of a serious medical issue and sort out data, they're really shocked by how many acronyms physicians tend to use, and it can be quite confusing. Radiation oncologists are no different. We have quite a lot of them. And tonight we're going to walk through each of these. So external beam radiotherapy is what we're going to basically spend the entire rest of my talk talking about, EBRT. There is a subtype of that called intensity modulated radiotherapy, which most patients that get fractionated radiotherapy for brain tumors receive. Volumetric arc therapy is a delivery mechanism, which is used quite commonly and is very powerful. Image-guided radiotherapy is really the standard of care, and we'll talk about that. We'll talk about SRS and SRT. It can be a little bit confusing as to what's different between those two modalities, and then a little bit at the end about some newer technologies and tumor treating fields. I think it's important to realize that these are not mutually exclusive techniques. Very often, for instance, for a glioblastoma patient, it's not uncommon for them to go through their entire course of therapy and receive absolutely all of these acronyms. So we'll kind of tackle each of them individually. But taking a step back, what is radiation? What is it and why do we use it? So radiation is really just the emission and propagation of energy through space or a material medium such as our body. Typically, we think of that as using electromagnetic spectrum or photons, but we can also use particles like electron, carbon ions, protons. When we're talking about radiotherapy that we commonly use for cancer treatment, we tend to be talking about ionizing radiation. However, some of the lower energy radiations are also used like tumor treating fields, which we'll touch on that. How does ionizing radiation work? When we say ionization, what we mean is that the incident radiation has an energy that is appropriate or enough to basically eject an electron out of its orbit and lead to the production of an ion. And what that means in terms of our body is that when we use radiation in this fashion, we can either cause these ionization events directly in DNA itself. However, within a cell, the DNA takes up a very small part of the volume, whereas most of the cell is water. So most of the damage that we do in cells are actually through an indirect route through causing ionization events in the water adjacent to the DNA and leading to indirect damage within the DNA itself. And what we accomplish by this is that tumor cells, we take advantage of the fact that tumor cells by nature of actually being cancerous have problems with their DNA repair apparatus. And so once we damage them, they generally cannot repair this damage. Whereas normal tissues, if we give a small enough dose of radiation per day, can repair that damage usually within 4 to 6 hours of the delivery of the radiation. And so we bank on that difference between normal tissue and tumors. By the end of a course of radiotherapy, ideally we've done enough DNA damage that these cells cannot divide, and when they try to divide, the tumor cells will die. And so just taking a step back, I think the older I've gotten, the more interested I've gotten in history of all forms. But I have to say it was only kind of recently that I started looking back in my own field at, why am I doing all of this and where does this come from? And so radiotherapy actually really got started back in the late 1800s. We discovered X-rays in 1895. Röntgen discovered that. This is his wife's hand. It's the first X-ray. And they used to produce X-rays with cathode ray tubes, or it was the kind of the era of the incandescent light bulb, and it was some of the science that kind of led to sort of advancements beyond incandescent light bulbs into producing X-rays with cathode ray tubes. And a question for the audience, how quickly do you think it was after the announcement of the discovery of X-rays before X-rays were used to treat patients? Any guesses?
No, probably not very quick.
60 days.
60 days. You must have been at my prior talk. I've given a talk on the history of radiotherapy, but it is in fact 60 days, which I found to be incredibly shocking. So the first radiation was given in January of 1896 at Hahnemann Hospital, which at the time was in Chicago, by a second-year medical student, E.H. Grube, who happened to also own a light bulb factory. And so is a very weird constellation of events, but he was he was a smart young man, and he was really interested in what you could do with light bulbs, and he started developing these Crookes tubes or cathode ray tubes, and he played with them. And his hands got very red and desquamated, and he started having radiation skin reactions, not knowing what was happening. And he kept up. I guess news did travel quickly despite not having the internet in 1895 with the current level of science, and he heard about these x-rays that had been discovered by Röntgen. And he's correctly assumed that that must be what was going on with his skin. And one thing that I found most interesting is back at that point in history, homeopathic medical schools were nearly as common as allopathic, and probably even more common. And many of you probably know there's kind of a central tenet of homeopathy, which is the type of med school he went to, that they like to use for their remedies things that actually cause in normal patients the same reactions that they're trying to treat. So when he realized, oh, well, these x-rays cause all of this desquamation in my skin, let's use this to treat patients that have similar desquamative issues. So lupus patients, breast cancer patients were kind of the first patient. So lo and behold, he brings it to his school. They allow him to take patients to the light bulb factory, and he treats them, the first patient, on January 27th of 1896. I doubt she got much of a palliative benefit, but she was actually a breast cancer patient. This is E.H. Grube. He actually did go on to do sort of more science in the field. Radiation, was one of the first radiation oncologists. And sadly, those are E.H. Grube's hands, because he really did handle those tubes directly, and that was the consequence after many decades. So now we're going to jump forward to modern era, where things are quite different than producing x-rays with basically light bulbs. Now we produce them with large machines. Dr. Murkow showed you a picture of a modern linear accelerator. This is another picture. Most linear accelerators actually rotate around a central point in the room. Here you see a prostate cancer patient that's lined up to that point, and the machine rotates around it. This is just the history of external beam radiotherapy and linear accelerators. Started in around the 1950s. Pretty rapid advancement in terms of the energies of the beams that we could produce, but we couldn't really do things that I find very interesting until the invention of computers. And the ability to have computer-controlled linear accelerators so that we can sort of move things in real time in the head of the machine. So here you'll see kind of the opening of the machine with these leaves that kind of move in and out. Prior to that, the way that we shaped radiation is individually per patient. We would physically draw blocks and have them poured out of a metal material, and we would shove them into the heads of the machine. And it was very laborious and time-consuming and a little bit dangerous putting these things in over patients. So when these leaves came out, it was a real sea change in radiation oncology, so we could quickly change between different fields. But we still used static fields, and we shaped them and treated through one open aperture. It was about 20 years later, though, that computing technology and three-dimensional imaging all sort of hit this nexus that allowed us to develop something called intensity-modulated radiotherapy, which is the most common type of external beam radiation today. And what intensity-modulated radiotherapy is you can see here, these are radiographs where basically you can almost see the shadows of the individual leaves, where basically the leaves will close and you can have a small amount of radiation that moves through them, and that's kind of the dark areas. And then you can, in real time, as the beam is on, you can change where those leaves are, and you get a little bit more radiation that kind of comes through, and you do this in an iterative process and sum it all up, and at the end of the day, you've created a dose distribution that varies in its intensity in real time as you treat the patient. So that's intensity-modulated radiotherapy, incredibly powerful. You can paint almost anything with it. This is actually a picture of Einstein that's made with an intensity-modulated radiotherapy plan. This is a patient of mine. It's very useful, especially in brain tumors. This is a meningioma patient where we needed to try and loop around and spare the optic nerve, and you can do that very nicely with IMRT. So definitely kind of a standard of care for patients with glioblastomas and many types of brain tumors. It's really quite standard of care. This is a quick video to kind of demonstrate two of the other acronyms that we talked about, volumetric arc therapy and IGRT. So that's the head of the machine. You can see that we can dynamically move the leaves, we can dynamically move the jaws and modulate the field in real time. As I said before, typically we would leave the fields in a static position and we would treat 5 or 6 of them per treatment. Now we utilize the fact that the machines can rotate and that we can in real time change the leaf position as it rotates to do something called volumetric arc therapy, which I'll show in a minute. The other advance is image-guided radiotherapy, which is what you're seeing here. Modern linear accelerators not only produce treatment X-rays, but they have arms that produce regular imaging kilovoltage X-ray beams, and they will allow us to actually create a 3-dimensional image, a CT scan in essence. This is a cartoon of a CT scan that looks nothing like a CT scan, but it allows us to see targets and normal tissues, and then we can in real time at the machine fuse that with our planning target volume. We can calculate subtle changes in translation and rotation of the patient and move them robotically into the correct treatment position. Most of our positioning systems for brain have an accuracy of plus or minus a millimeter, and even more accurate for stereotactic radiosurgery systems. So that's image-guided radiotherapy. Here you see that the patient's treatment has actually started, so you can see that we're treating continuously as the beam rotates around, and that holds several advantages. Number one, it's really fast, so 25-minute treatments down to about 5-minute treatments. It also allows us to constantly focus on the tumor and spread out the low-dose radiation around the entire 360-degree circumference of the patient, and that allows us to keep the intermediate and high-dose isodose lines very tight to the tumor and not have large spikes that would kind of come in and out of the patient's body, which is how it used to be 7 or 8 years ago even. Now you see that all of those intermediate and high doses are really kind of tightly conforming to the tumor. Here you see IMRT in action. So these 3 modalities, I would say, have completely transformed modern external beam radiotherapy, and any of you that have gotten a fully fractionated course of radiation for brain tumors likely got a combination, if not all 3 of these. And so what are CyberKnife and Gamma Knife? I've focused a lot on kind of standard isocentric linear accelerators, but for brain tumors, you can't really have a talk without addressing these technologies. They are other ways of delivering external beam radiotherapy, and they have their own pros and cons. CyberKnife is shown here, so it looks like the alien from Aliens, but it's an incredibly cool device. That is a small linear accelerator that is now mounted on a robotic arm, and this is a robotic couch, and so the couch has lots of degrees of freedom. This can move in all sorts of directions. It's not isocentric. CyberKnife, originally designed by a neurosurgeon at Stanford to give stereotactic radiosurgery and stereotactic radiotherapy for brain tumors, but it's pretty versatile. We can treat almost any spot in the body with CyberKnife. Gamma Knife is a machine that's been around for quite a long time. It came out sort of middle part of last century in Scandinavia. And it uses gamma rays, which are basically just X-rays that are produced with a naturally decaying radioactive isotope. In the case of Gamma Knife, it's cobalt. So there are usually 205 cobalt sources that are arranged within the head of that machine. And there are collimators that the patient's head kind of goes within, and we can collimate those beams that actually hit the patient to all sorts of different sizes. The modern Gamma Knives actually have collimation that can move in real time. That's kind of the new advance with that. Gamma Knife is specific only to brain tumors. We really can't treat things outside of the brain or the upper spine with Gamma Knife. So they tend to be only located in very big academic centers where there's enough volume to have a dedicated machine to only treat brain tumor patients. So getting back to kind of our initial roadmap, I think we've gotten through most of these. I started to touch on stereotactic radiosurgery and stereotactic radiotherapy. So we'll kind of move there next. This is just kind of a general broad overview of the different external beam treatment types. So we mentioned full fractionation and then stereotactic radiosurgery we have yet to really talk about, and stereotactic radiotherapy. So the difference between SRS versus SRT is really just semantic. If we give all of the radiation in one fraction, we call it stereotactic radiosurgery. And that used to be all that we did with this technique. Once we were able to move this technique from Gamma Knife to things like CyberKnife and linear accelerators, it was easier for us to give multiple fractions, and so that sort of led to the advent of stereotactic radiotherapy, which means that we just divide it up into 2 to 5 fractions in the US. The 5 fractions is somewhat arbitrary. It's based off of insurance companies saying that they will only pay for 5 fractions if you call it stereotactic. Other countries are smart, and sometimes they fractionate a little more fully than that out of concerns for safety. But the difference between all of these techniques is mainly number of treatments, right? So full fractionation, most of those regimens are somewhere between 20 to 30 treatments. SRS is 1 fraction. SRT is 2 to 5 fractions. The latter two are really ablative techniques where we're using incredibly high doses, and what we hit, we tend to kill. So we don't tend to use those techniques for more diffuse tumors because we can't really include a large volume of normal brain. We also have to be very careful about critical structures that are nearby, and those sorts of things, size and critical structures, can really determine whether we choose a single fraction versus multiple fractions. And radiation oncologists don't always make that choice themselves. You know, in a good department, you're going to be doing SRS and SRT in conjunction with a neurosurgeon, and we have these sorts of discussions about potential side effects and make a decision collectively as to how we want to proceed. So that's basically the difference between those techniques. And what we use kind of depends on tumor types. We talked a little bit about astrocytomas. They tend to be diffuse. So depending on what we use, we tend to use fully fractionated therapy because our volumes are also diffuse. And there's a lot of normal brain. And we want to go back to that tenet where we give small amounts of radiation each day to let the normal structures repair in between treatments to kind of maximize that therapeutic index between the tumor cells and normal cells and how they respond to radiotherapy. So patients that have astrocytomas tend to get a protracted course with or without chemotherapy. Now we are starting to use stereotactic radiosurgery and stereotactic radiotherapy more often for glioblastomas and other astrocytomas for focal recurrences. And that's getting a lot more play now than it used to when I first began my training. These are kind of other common malignant brain tumors, and you see with those that there's not often much of a preference between one technique versus the other based off of the tumor biology itself. It really all depends on size and location and other patient issues as to which one we choose. There are side effects with any radiotherapy for brain tumors. The acute side effects that I mentioned here are more common for the broader, fully fractionated radiation where our volumes are quite big. So fatigue, hair loss, radiation dermatitis, peritumoral edema or swelling in the tumor, possible increased incidence of seizures if you have a fair bit of swelling. So these are all quite common. They tend to get better and go away pretty quickly once the radiotherapy is done. But there are chronic issues after you've been radiated. So we always tell patients radiation is kind of the gift that keeps on giving. And that's because your body basically, you know, despite the changes that we make to the DNA, your body produces other signals in response to radiotherapy, and it kind of remodels. And that can lead to other changes. So in the brain, in particular, we worry about neurocognitive decline after large volume radiotherapy. We'll talk a bit more about that. We also worry a lot about this issue called pseudoprogression, which is really an annoying thing that we have to contend with as we follow patients who have been radiated. So radiation, either fully fractionated or stereotactic radiation, can cause changes on imaging that look like progression, but are not necessarily progression. And it's in one of these other reasons we've talked a lot about multidisciplinary management, and this is one of the reasons why I think it's incredibly important for the medical oncologist, the neuro-oncologist, the neuroradiologist, the neurosurgeon, and radiation oncologist to all be involved in looking at films and trying to decide, is this person progressing on their current therapy, or is that just radiation change? And it can be complicated. Radiation necrosis is listed down there. I think that's one of the most difficult things for patients to deal with and for us to deal with as physicians. We have made some advances in that. What basically it is sort of you've created a nidus of inflammation within the brain that can either be sort of dead or dying tumor cells or dead or dying normal brain tissue, and your body just really does not appreciate that it's there. And you can get a lot of inflammation, a lot of swelling. We used to only really be able to manage it with chronic steroid use, which can be really devastating to be on, or surgically removing the nidus of this inflammation. Dr. Chen now has in her armamentarium a really effective medication called Avastin, which used in low doses can really help control radiation necrosis quite nicely, but it is still a big problem. So what do we do? What are we looking at in the field to try and mitigate some of these side effects? There are numerous things. One that's really interesting is medications, neuroprotective agents. There is one that has gotten A lot of research has been done. There's actually randomized data for memantine, which is a medication that's used standardly for moderate to severe Alzheimer's disease, but it's been studied in whole brain radiotherapy. So whole brain radiotherapy with or without memantine has been looked at in a randomized fashion, and memantine has been shown to improve neurocognitive function long term. So I have seen a lot of neuro-oncologists, especially the ones at UCSF, recommending that patients, even with gliomas, consider using memantine along with their radiotherapy for neuroprotective effect. It's a 6-month course of treatment that you do during radiotherapy and then afterwards. There's also some evidence that there may be some anti-tumor effect directly from memantine, and there are some early studies, phase 1 studies, looking at that actually upfront in therapy with radiation. There are planning advances, and I spent a long time on this talk kind of touting what we can do now with our planning, and it's paying off. So we've done studies in whole brain radiotherapy where we've used IMRT to basically create these holes right in the middle of the brain in terms of dose, where your hippocampus lies. And your hippocampus is involved with memory and short-term memory formation. And there's data as well to show with whole brain radiotherapy that hippocampal sparing is, number one, safe. It doesn't seem to cause more failures within the brain. And number two, can lead to improvements in neurocognitive function down the line. So it's a nice technique. In the glioma world, we've kind of taken that data from the whole brain world. And most of us are really thoughtful about how we control doses to areas of the brain like the hippocampus that are not maybe directly involved with the tumor. And then there are new techniques called tumor treating fields, which I find really fascinating. And there's a gentleman here who's using them, which I think is great. But what they are, for those of you who are unfamiliar, is basically using a different type of electromagnetic radiation. Basically, we're using electric fields that you wear transducers on your head that are designed specifically for you based on your tumor location to try and pull as homogeneous of an electric field across the tumor as possible. And then we alternate that field in different hertz based off of the type of tumor that we're trying to treat. So this is not a brain-only treatment, although the brain is kind of the easiest organ to really get a nice homogeneous field. So that's where it was studied first. But we use different hertz for pancreatic tumors and mesotheliomas and glioblastomas. So we pull this alternating field and it completely disrupts our ability for tumor cells to divide. So for cells to divide, you may remember from high school biology, it requires these things called microtubules, and microtubules line up to each other based off of electric charge, right? So if you're disrupting their ability to line up, then these tumor cells will potentially die as a result of that. So that's how it works. I will say, again, looking back at history, the guy who first came up with this idea was sort of laughed at. No one's really laughing at him anymore. So this technique has proven to be very, very useful. And so Dr. Chen talked a lot about this kind of standard of care for glioblastoma being Temodar plus radiation followed by Temodar. This was established as the standard of care in the early 2000s, and a lot of things have kind of gone up against it, and nothing has really beaten it until tumor treating fields came along. Interestingly, the same primary author that wrote that first game-changing paper back in the early 2000s was the same author who looked at this. And there was a better overall survival at 5 years for patients that added tumor treating fields post-radiation to their adjuvant Temodar. I will say, it can be a difficult treatment for patients to undergo. It requires some lifestyle modification, but I think once patients really get into it, they find they can do a lot of the things that they really like to do despite having to wear this. I think one interesting thing as well is one of my colleagues, we do a lot of pediatric radiation oncology over at our Berkeley office. We treat all the kids from Children's Hospital Oakland. And so one of my colleagues is actually designing the first trial looking at Optune in children with glioma. So you saw Dr. Chen's slide, a lot of kids get primary brain tumors, and it hasn't really been looked at in them. So we've actually got Stanford participating and UCSF participating. And we're hoping to get some data to extend this to younger patients. I think the original trial was 22 and up for TTF. And so I think that basically does it. I think we've hit all the acronyms. Hopefully they make a little more sense. And I think what we've all kind of stressed in all of our talks is that we have lots of things to use. Some of them are great, some of them can be dangerous, and we have to really talk in a multidisciplinary fashion and take into account lots of different factors about the patient to figure out what the right treatment is for you. So thank you.